Oh, that's wasn't all my fault.
What?
Oh, too late. I'm recording. Okay. So sepsis, which is, no, can we look? No, I just wrote them for you for nothing. No, I'm just kidding.
Bacteria in the blood.
All right. Bacteria in the blood came from somewhere.
Okay.
So who are the patients that are most at risk of sepsis?
Immunocompromised.
Immunocompromised. I can agree with that. That was good.
Oh, could be like chemotherapy.
Yes, if they were immunocompromised, sure.
People with
Thank you.
Foley's.
Patients with Foley, sure. Like a CAUTI that went wrong.
People in the ICU. Intubated patients.
Okay, so intubated patients would be more at risk of VAP, which would then lead to sepsis. What patient population is for its age?
The
Elderly and
Yeah.
little babies, especially less than 1 year of age, correct? Because they don't have a full immune system until they're one. And then our patients with like chronic diseases like diabetes, because they have compromised blood flow. That's correct. Right. Right. So you get things like ulcers and those get
Yeah.
infected and they can't heal. And then,
Yeah.
oh, y'all are just going to agree with me. Great. All right. Okay. Okay. Any massive invasive lines, but especially central lines, those are high risk of infection. Yeah.
Yes.
Okay. What else you got?
Meningitis.
Yes. Meningitis. I can agree with that.
Pneumonia.
Oh, now you're just going to give me causes. Okay. Yeah, we're still on risk factors though. Yeah. So,
Could an art line? Or is it just
art line,
smoking?
probably not. That's not
Smoking?
very infected. I mean, no, smoking doesn't really, I know one of the only times that's not a risk factor. Huh?
A pulmonary cath.
Pulmonary artery cath. I think that would be a bigger risk of bleeding.
A chest tube.
No, what? Okay. I don't know how to help you. Let's think of it in a different way.
What a malnourished.
Why?
Because they're malnourished. They don't have the nutrients
Like what?
like glucose. Proteins.
Oh, okay, protein is probably better. Okay, I can go with that. Okay, what else? How about HIV?
Yeah. Oh.
Okay, what are patients like sepsis means that there's an untreated infection, right? So what are patients that would have an infection that we did not catch that would go untreated?
Correct.
Let me ask it in a different way. Sorry. Okay. What are the patient populations that may have some kind of infection that we wouldn't know about?
Sexually active teens. No,
Okay,
didn't.
let me ask it in a different way.
Okay.
Who might get an infection that wouldn't tell us with their mouth that they had some kind of an infection, they couldn't communicate with us? Okay, intubation is a big one. Like patients with dementia, Alzheimer's, we know they typically die of a comorbidity, like a UTI that goes to pyelo goes to sepsis, right? We talked about that in dementia and Alzheimer's.
Yes.
Yeah, you feeling it now. Okay. Something like that. So patients that are completely nonverbal, they're going to be at high risk because by the time we actually, like, you have to be very in tune to the signs and symptoms. You'll see what I mean?
Yeah.
Okay, so like neonates, that could happen very easily too. I'm just going to move past the risk factors because this is not y'all's best moment and it's painful. I'm in physical pain. All right. So now you can give me the most common sources of infection. What's a number one? Oh, I've got a package. What's a number one source of infection that will lead to sepsis? Pneumonia. That came from the lung. All right. What are some other ones? UTIs that led to so pyelo and then into sepsis. Yeah. Okay. What else? Endocarditis. And what was the other big one we talked about? Thank you very much. Don't also do not forget your big abdominal ones like neck. Okay, actually, I can agree with you. Neck is actually possible. Necrotizing enterocolitis for our babies. Peritonitis, what's your red flag?
Rigid
bore-like abdomen, and that can come from, where do you get peritonitis?
Like dialysis.
Oh, actually, that's true. You're right. I was going to say you're stupid, but I'm not. If you're getting peritoneal dialysis, that absolutely could happen. What are your most common abdominal illnesses that can cause peritonitis? Like a ruptured appy. These are not hard questions. A ruptured spleen? Ma'am, no. How about like a bowel perforation?
Yeah.
I'm starting to get the feeling y'all do absolutely zero prep work before you come here. Is that correct? Oh, y'all did do prep work?
I watched Jared's video. I watched.
Well, that didn't go good. Okay. So we're going to do a septic workup. We need to find out what the main, like, where this is coming from. So give me what your septic workup, knowing where it's coming from, what your septic workup going to include.
CBC.
CBC, because I'm looking for high white blood cell count. Are you okay? We good? All right. What else are you going to do?
Blood
Chest
culture.
X-ray.
Blood culture. We're going to do a chest x-ray to look for
Pneumonia.
The white.
pneumonia. Ma'am. Okay, we're gonna do chest x-ray. We're gonna look for pneumonia. What else are you gonna do? We're gonna do a lumbar puncture. We're looking for
Bacteria. And this.
meningitis. Correct. Yeah. Y'all remember the big 5 septic workup? CBC,
Blood culture.
chest x-ray, blood culture, lumbar puncture.
Lactic acid, right?
But we're looking for sources at this point.
Urine output. No.
We're looking for sources.
Sputum.
Well, we did chest x-ray.
Oh.
Where do we say the,
BMP.
we're looking for sources. I want to find out where the bacteria is located. I will go back to the most common causes and think, what have I not run yet?
You would check the urine.
You would do urine
Culture.
culture.
Oh, we already said that.
No,
Oh.
no, someone said urine output, which didn't help me. You understand those 5 things? That's called a septic workup. We're looking at 5 different places to see where the source of the infection is.
Okay.
Great. Okay. If they are hospitalized and we're doing a septic work, like they've already been in the hospital for a period of time and we're like, oh no, I think this patient's getting septic, then who probably made them septic? It's probably you. Yeah. So what am I going to add to a septic workup if they're already in the hospital? Go.
Do we check the tubings?
Yes. Like
The Foley?
you're going to remove the Foley and you're going to send it the culture, right? Like, and they can actually culture the Foley. Okay.
Yes.
Central line.
The central line. Okay. They're going to replace the central line and then you send that central line to the lab and they'll culture the tip, right? Go on.
Can you replace their their ET tube?
You
that
can
on?
replace the ET2, but it's probably not infection inside of there,
Mhm.
right? It's probably in the.
Could you check if they have like an ulcer, like a pressure ulcer that got infected?
Sure, you could check their skin and look for a pressure ulcer that maybe we didn't see or something like that, right?
Mhm.
All their IV sites are basically gonna have to be redone, cultured and sent, even if it's just a regular peripheral IV. Don't understand.
Mhm.
Okay. If there are any wounds, you do have to send off a culture on those. Yeah.
Yeah.
Even if they were in there for that. Okay.
Mhm.
Okay. If they are vented, then we'll just do a sputum culture. Like we'll just stick a section in there and make them and then try to collect. Good luck. Or you can section it out if you want.
Alright.
Yeah.
Mhm.
Okay. All right. So let's run some labs now that we think this patient is septic. What do you want to run? Lactic acid, CBC. We already sent a blood culture. Yes. We already sent a CSF culture. We already sent a urine culture. CMP, which is going to include BUN, creatinine, liver functions, kidney functions. Yeah.
Yeah.
All right. How do I explain this? Okay. If you think a patient is starting to like, you get that feeling where you're like, oh no, something's off. Okay. What am I going to do first? You just got the feeling. All you got's the feeling. I got a feeling. But you don't know they're septic, right? So how do you know? How do you know a patient is septic? How do you very quickly know a patient is septic? Like
Your temperature.
how could I know within the hour that a patient for sure is septic?
One of their cultures come back.
Well, cultures take 3 days, so I don't have time to wait for cultures,
Lactic
right?
acid.
Thank you, ma'am. So the first thing you're going to do is to draw lactic acid, right? Because I can do that super quick. Yes. You're going to really quickly get a blood culture. I'm just telling you like your order if you think that the patient's septic, right? All right. So do your lactate level. We got a blood culture. And then what's the very next thing you need to do? Like, boom, antibiotics, right? Even because we're suspecting, but we're like, this ain't looking good, right? Probably by the time you're ready to start antibiotics, because you know, blood cultures take a while to draw because you have to draw usually 3 different vials from 3 different spots. Y'all do know this, yes?
Yes.
Okay. All right. So then after we did the antibiotics, what's this patient going to need immediately? Fluids. And then we're going to give pressors. You understand the top 5 we're going to do?
Yes.
Okay. So I walk into a patient's room. I'm like, this is fishy. They had pylo last week and now they're coming in and they're really not feeling good and they're not very conscious. So number 1, lactic acid. Number 2, draw blood culture. Number 3, antibiotics. Number 4, fluids. Number 5, pressors. Okay. That's kind of how you're going to do. On the exam, they might set you up like that, or they may just say, hey, you have a patient that is suspected sepsis. What's the first treatment that you would do? That would be antibiotics. You see what I mean?
Yes.
Okay. All right. And then as the patient, like, let's say we got it back and their lactic acid level is 12. Yeah, it's going bad. Yeah. So they're going to need some massive fluids, pressors, all kinds of meds, right? So what do you think you're going to probably want to start? A central line, right? Because we're going to be giving a lot, right? And I don't have time to watch this IV site.
Yeah.
Okay. What are the 2 biggest assessments you need to be monitoring on this patient? What they have right now is sepsis.
The kidney function?
Yes. But more so urine output, right? So how will I know they're starting to go into shock? Urine output's going to start to decrease. So I'm like, shit. So you're supposed to keep increasing fluids until the urine output is adequate, right? So I need to watch out really close and watch what's the other assessment? Urine output and lactic acid we did. We know they're septic, right? What's the next thing that could happen to your patient after sepsis? Right after sepsis. Right after sepsis.
Sure.
Thank you. So if we're worried about shock, then we need to watch their blood pressure very closely. Yes? Okay. So we're going to do blood pressure and urine output very, very closely. You with? Okay. Then we're going to start to watch for signs of shock, which would be low urine output, right? BUN and creatinine are going to start to increase. Yeah. Then you're like, oh no, that is called shock. And now we're worried. The next step we're worried about is mods. Okay. So how I know they're going into mods.
Altered mental status.
All right. So altered mental status would be a brain thing. Yeah. Hypoactive or absent bowel sounds, paralytic ileus. Yeah.
Even lower blood pressure.
Huh?
I said even lower blood pressure.
Yeah. Blood pressure could probably tank even more. What about in the lungs? What are you going to see? They're probably going to start at first, right? Right. We're going to have tachypnea, dyspnea. Okay. How will I know that they're going into like lung failure? Okay. So ABGs can help me. What is the disease that they will go into whenever the lungs have failed? They're going to go into ARDS, right? So the lungs are going to keep filling with fluid. All right. What about kidneys? How will I know that the kidneys are just shot? Little to no urine outputs. BUN and creatinine are very high, and I'm going to have to put the patient on CRRT. Very good. All right. What about liver? How will I know they're going into liver failure? They may start to get itchy. They're going to start bleeding. Their ALT, AST, alk phos is going to increase. Bilirubin. High. They're going to start to turn kind of yellow. Got me? How do I know the CV system is dying? Decreased cardiac output. They're going to go into what looks like heart failure, which is not good for ARDS because we was already full in there. Yeah. How do you know? We talked about GI, right? Oh, y'all know almost everybody whose GI starts to die gets massive GI bleeds, and then their liver doesn't go far after that, right? So this patient is just going to literally be oozing blood out of their bottom. Okay. So in order to keep their gut from dying, what do? Feed them. So we're going to start enteral feeds as soon as possible. Yes. All right. There is a protocol out there for sepsis that is better than just antibiotics called the MERIC protocol. Have you heard of this? High dose vitamin C. It's an actual thing. So they did a ton of research on it, and they found that high dose vitamin C, which is 1.5 grams of vitamin C every 6 hours for 4 days, plus big doses of hydrocortisone and thiamine works better than the antibiotics. Because what you're doing is basically giving them a massive amount of your own immune support so your immune system can start killing things off. Because when the antibiotics rapidly kill off that bacteria, remember they give off endotoxins and exotoxins. If we can use this protocol, it doesn't do that as much. So their survival rate after sepsis for a patient on the MERIC protocol is much better than if you just put them on massive doses of antibiotics. Because the other thing you got to think of too, if you're putting on a massive doses of antibiotics, almost all antibiotics are toxic to the kidney, and you're worried about kidneys. So do we understand? All right, you understand the basics of sepsis? Okay.